So I'm going to talk really about thrombotic microangiopathies in the context of acute presentation with kidney injury, and we'll spend the second half really talking about complement and its role in these disorders. My conflicting interests include honoraria and consulting payments by Alexion, which is the company that makes eculizumab. So obviously it's important that you're all aware that I do have links with this company, although the opinions that I'm going to express are my own and not in any way the company's. So I'm going to start with a brief history, and we'll come back to this case this afternoon. A 28-year-old Bulgarian woman who lived in London, previously well, and she presented to her local hospital 3 o'clock one Friday morning with abdominal pain, headache and vomiting, and gave a approximately 2-day history of these symptoms. She also had reported a patchy rash over the last 2 weeks associated with symptoms that were consistent with a viral infection, feeling generally under the weather without any specific symptoms. Importantly, she had no diarrhea, she had no significant past medical history, there was no family history, and she had one healthy daughter born 6 years previously. So examining her, she was tachycardic, respiratory rate was 24 but saturating normally, and there was a very sparse purpuric rash visible on the legs. She was euvolemic, and other examination were normal except for urinalysis, which did show some microscopic hematuria, and beta HCG testing was negative. Her blood tests were done, and they showed that she was anemic and thrombocytopenic with an elevated LDH of over 1,000. This isn't her blood film, but this is a blood film that might be seen and shows evidence of schistocytes, reduced platelets, appearances consistent with a microangiopathic hemolytic anemia. Her creatinine was elevated, but her LFTs were normal. The CRP was 29, and her white cell count and coagulation were also normal, and her direct antigen test was negative. She also had normal imaging studies, and on the basis of these results, she was transferred to the renal unit. So, has anyone got any thoughts about differential diagnosis? HSP? It was 140 over 90. HUS, yeah. AHHUS. TTP, yeah.
What was the blood pressure?
140 over 90.
Did you have any neurological symptoms?
No. So there's a fairly broad differential, and you've said most of the important ones. Clearly this is consistent with hemolytic uremic syndrome. We've got a microangiopathic hemolytic anemia. TTP, this could be a presentation of SLE with antiphospholipid syndrome. Accelerated hypertension and preeclampsia, excluded really on the basis of the blood pressure and the negative pregnancy test. Infection is also important to consider in this context, and obviously drugs can do this. So for her, well, we've really excluded accelerated hypertension because her blood pressure isn't really high enough, though of course we don't know what it was prior to her presentation. Seems unlikely. She's not taking any drugs, so that renders that side of things pretty unlikely. Her LFTs were normal, and she wasn't really systemically unwell enough to make an overwhelming bacterial infection likely at this point. But clearly, other infectious agents and, of course, the autoimmune and primary thrombotic microangiopathies would be possible. So she had an urgent ADAM TS13 level sent, which came back as 40% of normal. And this result was available 9 hours after her initial presentation to A&E. And that was because the very alert A&E team had referred her, had couriered the blood to the reference lab. They'd got on the phone and they'd done a very good job. Considering the patient presented it on a Friday morning, it was great to get this result back so quickly. She had an HIV test which was negative, an echocardiogram was normal, transthoracic one. And the sort of renal screen came back and was all negative, although these results only were available after the weekend. But she was very rapidly dialysis dependent. So that really helps us quite a lot. The normal or the mildly suppressed ADAMS TS13 level excludes thrombotic thrombocytopenic purpura, in which, as we'll go into later, you would expect an extremely low ADAMS TS13 level. And the negative serology excluding HIV, SLE and autoimmune disease, and the normal TT really argues against endocarditis. So having excluded most diagnoses we're left with hemolytic uremic syndrome. So, of course, not proven at this point. So what are the things to consider in the management of a patient presenting like this? Well, the first point to make is not to give platelets, because this really fuels the fire, and her facial expression is one that you'll see again if this is what happens. The other principles are to control the blood pressure if it's elevated, support the organs as necessary. And really it's absolutely critical to understand what the cause is and to treat the cause as promptly as possible. And this is not always possible because the specialists and confirmatory tests are not always available as quickly as one might like them. But it is important to remember that even somebody presenting with dialysis requiring renal failure, as this patient did, that renal recovery is often possible. And it's also important to recognise that these conditions, anything that causes a TMA can also manifest with neurological deficits which may be permanent, and death can occur. And we'll talk about a few cases later on this afternoon where outcomes weren't as one would have wanted. So what is actually causing thrombotic microangiopathy? Well, there's clearly a very long list of different drugs and conditions that this is associated with, but the key thing to remember is that TMA is really a manifestation of systemic damage to the endothelium. And this results in a cascade of platelet aggregation, microthrombosis, and then infarction of the organs. And when you do a biopsy of an affected organ, that's what you see, a thrombotic microangiopathy. The systemic test that you can do is a blood film which shows appearances which I put up earlier, which we term a microangiopathic hemolytic anemia, and that's really the blood film manifestation of the histology that one sees and describes as a TMA. The kidney and the brain are particularly susceptible because of their fine network of capillaries, but it's also important to recognise that the heart, the gut, the lungs, also the liver can also be frequently affected. And because almost any organ can be affected, it's not always possible to determine what the cause of the TMA is just from the clinical consequences, although it's well recognised that different etiologies have different organ predilections. So one might expect to see neurological impairment in patients presenting with TTP. This isn't always the case. It's not always possible to exclude or confirm the diagnosis based on an individual patient. And the treatment of these disorders really does depend on the underlying cause. So this is a diagram of a small blood vessel showing some erythrocytes and some von Willebrand factor, which is normally cleaved by this enzyme ADAMTS13, which is a metalloprotease that's present in the circulation. And this limits the size of the von Willebrand factor multimers that can aggregate. Where you have deficiency of ADAMTS13, what you get is the build-up of von Willebrand factor to form these very large protein complexes. And you normally need some sort of endothelial irritation or damage to spark off a cascade of pathological platelet plug formation, microthrombus, and secondary organ damage. So TTP frequently has an identifiable trigger, although not always. Now, a contrasting mechanism is direct damage to the endothelium, and this can be either due to overactivation of complement, or it can be due to exposure to toxins or drugs or radiation or anything that damages the endothelium, then leads to a platelet plug forming, a microthrombus developing, and the consequence of whatever the mechanism is thrombotic microangiopathy and organ failure. So you can't tell clinically whether it's a primary endothelial damage due to either an intrinsic or extrinsic agent, or a primary problem with the metabolism of the von Willebrand factor multimers that's actually driving the process. So this is a sort of diagram summarising the main categories of causes of thrombotic microangiopathies, with TTP and HUS here, and then drugs and other causes such as accelerated hypertension, autoimmune diseases down here. And I'm going to spend the rest of this talk really concentrating on TTP and HUS because the treatment and approach to these other conditions is really dependent on what the actual driving factor is. So TTP is very rare. Its incidence is estimated to be around 6 per million per year, maybe to an extent under-recognised, but it's certainly not a condition that presents very commonly. Historically, the mortality from this condition is extremely high. Almost every patient in the initial descriptions of this disorder died without treatment. And the diagnosis is most strongly suggested by sort of fluctuating neurological deficits in the context of microangiopathic hemolytic anemia. Renal impairment can be present at presentation, but is rather unusual. Up to 50% of patients can have an elevated troponin, and there is frequently subclinical myocardial disease in TMA. But the presentation can sometimes be with microangiopathic hemolytic anemia only, and of course in that context it will most likely present to haematologists. And as I said before, the cause of this disease is either congenital or acquired deficiency of this enzyme ADAMTS13, which cleaves von Willebrand factor proteases. So the diagnosis of TTP can be proven or excluded by a functional assay of ADAMTS13, and a level of less than 5% really proves the diagnosis. A level above 10% robustly excludes the diagnosis of TTP. And there are reference labs around the country that will do this in an acute setting. Now, the guidelines for the management of TTP are plasma exchange, and one recent publication I've just quoted here, that in view of the high risk of preventable early deaths in TTP, treatment with plasma exchange should be initiated as soon as possible, preferably within 4 to 8 hours, regardless of the time of day at presentation. If a patient presents with MAHA and thrombocytopenia in the absence of any other identifiable clinical cause. So the message for this is that if a patient comes in with TMA, and particularly with the organ involvement, plasma exchange should be started really rapidly. And I mean, 8 hours from presentation is fairly rapid to establish a patient on plasma exchange. Clearly, it's really important that even if an ADAMTS13 assay can't be performed before institution of therapy, that samples are taken for measuring them, because once a whole load of plasma has been poured into the patient, then it makes the assay difficult to interpret. So what sort of plasma exchange do we do? Well, the duration and the number of exchanges is variable and really depends on the clinical response. The current recommendation is for solvent detergent plasma, Octaplas, to be used because this is associated with reduced risk of infection, and typically of bloodborne infections, that is. And typically 1.5 plasma volumes are used daily until 2 days after the platelet count is normalized. If there are identifiable ADAMTS13 antibodies, sometimes longer durational plasma exchange is needed. Sometimes twice daily exchanges are needed for patients with very severe disease that's not responding. And if, unless you know that it's a primary genetic deficiency for the enzyme, steroids and rituximab should be started early on in treatment. Normally one would hope to get a reduced ADAMTS13 level back before immunosuppressing the patient. So for congenital TTP, which is a recessive disease caused by biallelic mutations in the genes encoding ADAMTS13, relatively low volumes of plasma infusion are needed to prevent disease. And ADAMTS13 is also present in a commercially available factor VIII concentrate, which, because of the way that it's purified, also purifies ADAMTS13. So this can also be used to prevent or treat flares of disease in patients with congenital TTP. Clearly, a logical treatment would be administration of recombinant ADAMTS13. That's not currently available, but there are clinical trials going on at the moment, and it's hoped that in the future this will be available. In acquired TTP, this is caused by an autoantibody against the enzyme, which therefore inhibits the enzyme. And in this context, typically very large volumes of plasma exchange are required in the acute setting, because one has to remove the antibody which is inhibiting the enzyme and replace the enzyme as well. And treatment aiming to suppress antibody production is also given, and typically this is with steroids and rituximab, although there aren't large cohorts of patients to guide really robust evidence-based guidelines. TTP can be triggered by pregnancy, and of course the diagnosis in a pregnant patient is not always straightforward, considering the pregnancy-related diseases associated with MAHA, which you probably heard about this morning. And this can be either congenital or antibody-mediated TTP can present in pregnancy. In patients with congenital TTP, there's now good anecdotal evidence that close monitoring of these patients and early treatment with plasma or factor VIII infusions is effective in reducing fetal loss from almost half of patients presenting with what turned out to be congenital TTP, having had previous fetal losses, to a very low loss rate in people who are under follow-up. So the other main category of diseases that present acutely with thrombotic microangiopathy are hemolytic uremic syndrome. And this is really divided into the rather clumsily named hemolytic uremic syndrome and atypical hemolytic uremic syndrome. But whichever form it is, the clinical triad is of anemia, thrombocytopenia and acute kidney injury are the classical features. But other organs, particularly the brain and the heart, can be affected. And as I said earlier, you can't distinguish it from TTP purely on clinical grounds. And the cause, as I mentioned earlier, is really a systemic damage to the endothelium with secondary microthrombus formation. Now, the cause can either be an exogenous, typically bacterial toxin, in which case we call this HUS, or an intrinsic, usually genetic disorder in a patient that leads to dysregulation of the host complement system, in which case we call it atypical HUS. The terms D positive, as in diarrhea positive, and diarrhea negative HUS are also used, but these are rather unhelpful, firstly because not all patients with bacterial infections will have GI involvement and diarrhea, and secondly that atypical HUS can present with a diarrheal illness because the gut can be affected, and in fact most patients presenting with atypical HUS will have GI involvement at some point in the course of their disease. So toxin-associated HUS is reportedly the commonest cause of AKI in children, according to some papers. Most of the identified causes are with E. coli that produce Shiga toxins, and the 0157 strain is the one that we'll encounter most commonly, but there are other strains as well. Strep pneumonia infection can also lead to HUS. That's a very small proportion of cases, and there are Shigella and Campylobacter infections that are associated with the disease. There's often a prodromal bloody diarrhea, which is a clue to this disease. And this does occur in adults, but is far more common in children. Other causes of TMAs presenting with features of HUS are in the post-bone marrow transplant setting, and also drugs. And the drugs include calcineurin inhibitors, which many renal physicians will be familiar with using, but also quinine, chemotherapy agents, clopidogrel, and many of you will have received an email this week about interferon beta and the association with TMA that's just been recognised there. But the other category of HUS, which probably accounts for about 20% of HUS in clinical practice, and possibly more than that in adult and exclusively adult practice, are caused by defects in regulation of the complement system. Now, complement is part of the innate immune system, and it's a circulating cascade of proteases which are present in the circulation, which we've known about for a very long time, since the 19th century. And it's really a crucial component of host defense, and it's conserved across evolution. And the essence of complement activation is to produce a very high amplitude, rapid response. And this is centered on an amplification loop that needs careful regulation. We call this amplification loop the alternative pathway. So bacteria are recognized by antibodies, and these then lead to activation of complement by the classical pathway. They're also recognized by mannose binding lectin proteins that are present in the circulation. And both these pathways lead to cleavage of C3 to form C3a and C3b. C3b then goes on to activate the terminal pathway by cleaving C5 to form C5b, which then forms the membrane attack complex and lyses cells. C3b also is able to bind to factor B, and the C3 protein and the factor B proteins are found really right across the animal kingdom in animals that more closely resemble plants than animals, like sea anemones. So this system is really absolutely fundamental to mechanisms that animals use to protect themselves against infection. And C3, the complex of C3b and factor B, is able to catalyze the production of more C3b. So this forms a positive feedback loop. And this C3 enzyme, C3BBB enzyme, is stabilized by a bacterial surface. So this feedback loop is going on all the time at very low levels in the circulation. But when a bacterial surface is encountered, it stabilizes the convertase and causes massive amplification of the signal, activating complement. Now, host cells are also able to stabilize this convertase and activate complement, but they express proteins on their surface, including membrane cofactor protein, thrombomodulin, and some other proteins that protect them against complement-mediated damage. The other mechanism that we have to protect ourselves against runaway damage by complement are circulating regulators of the complement system, and the most important one of these is complement factor H. Now, factor H can inhibit this enzyme in the circulation, but it also has an ability to bind heparins, which coat host endothelial surfaces, and particularly provide protection against complement activation at host surfaces. And it's this host surface protection by factor H which is really key to preventing atypical HUS. Now, the mutated genes that are associated with atypical HUS include mutations in C3 and factor B that activate this enzyme pathologically. Loss of membrane cofactor protein and mutations in thrombomodulin are also associated with atypical HUS. And the mutations in factor I and also factor H are most commonly associated with this disease. So genetic loss of these complement regulators causes complement dysregulation and atypical HUS. Now, it's important to recognise that C3 is one of the most abundant plasma proteins, and we measure it in milligrams per mil. So there's about 6 grams of the stuff in the circulation, which makes it firstly primed and ready to go off at the slightest provocation, but also a very difficult pharmacological target. And C4 is also an abundant protein, but the other components of the complement cascade all circulating at much lower amounts, and this will become important later. So in patients with atypical HUS in whom a mutation is found, about 75% of them have mutations in complement factor H. And these mutations all tend to lie in the C-terminal domains of the protein that impair its ability to bind to host surfaces. Complete deficiency of factor H causes a different phenotype. But there are also mutations in those other regulators which I mentioned, and very rarely antibodies. Patients can develop antibodies against factor H that block factor H and lead to runaway complement activation, rather in a similar way to what we see in TTP and Adams TS13 antibodies. So what are the things that make patients present with atypical HUS? Well, it's an episodic disease. Some patients with these mutations go their whole lives and never actually present with disease. So the presentation can be at any age. It can be in childhood or early adulthood, but in fact, you can see it presenting even in elderly people. There's often an identifiable trigger for the condition. This might be infection, it might be pregnancy, it might be oral contraceptive pill use, and also surgery. And these considerations are really important when you're thinking about live kidney donation in people with a family history of atypical HUS. But often we don't manage to identify a trigger for the acute flare. So how do we treat atypical HUS? Well, prior to 2011, the treatment was plasma exchange, and this was again plasma exchange against fresh frozen plasma to replace deficient complement regulators, remove any cytokines that were activating the complement system, and where antibodies were identified, immunosuppression or B-cell depletion can also be used. Kidney transplantation can be used in patients, or has been used in patients with atypical HUS, where a membrane-bound complement receptor is known to be responsible, because of course the new kidney will express normal complement regulators, so recurrent disease is unlikely, although it is still described. Where there's an identified circulating regulator of complement that's responsible, then clearly kidney transplantation is associated with a very high risk of recurrent disease following transplantation, so is relatively contraindicated. And because the complement proteins are predominantly made in the liver, some patients have undergone combined liver-kidney transplant to treat atypical HUS. However, it's important to recognise that the mortality of this condition, which has only been performed in a handful of patients worldwide, is 10%, which is very significant. So, as I said, the rationale for plasma exchange in atypical HUS is to remove and replace the deficient complement regulator. And the advice really is to commence plasma exchange as soon as possible. So in practical terms, it's not always necessary to distinguish TTP from HUS in order to institute therapy with plasma exchange. But what is important is that the samples for ADAMTS13 levels have gone off because the subsequent treatment, B-cell depletion and steroids, are indicated in TTP and are not usually indicated in atypical HUS. And clearly genetic tests to really understand the cause of disease in an individual patient can take weeks or even months to get back. So how good is plasma exchange in treating this disease? Well, the answer is there's clearly a beneficial effect. There's been no randomized clinical trials, but the outcomes in untreated atypical HUS were exceedingly poor, with a mortality of 90% or more. Even with plasma exchange, this does not completely treat the disease, and there was a population of patients who experienced ongoing thrombotic microangiopathy even with continuous plasma exchange. So there's an unmet medical need that's been known about for a long time, where plasma exchange is a treatment but not a complete treatment for the disease. So I've mentioned liver transplant. I won't go into that in more detail, except say that it's clearly not indicated where there's a membrane-bound complement regulator that's deficient. So a logical target for the disease is C5, which is the effector of the terminal complement pathway. And clearly, if this can be blocked, then the membrane attack complex can't form, and this might protect the endothelial surfaces, even if the proximal parts of the complement cascade are activated. So C5 depletion is therefore a rational target for the development of treatment. And because C5 circulates at much lower levels, less than a tenth the amount of C3, this is an easier target than C3. So eculizumab is a humanized anti-C5 monoclonal antibody that's been very carefully engineered so that it eliminates both Fc receptor and complement activation abilities of antibodies. And it's produced by Alexion under the trade name Soliris. So I've put up this slide which shows really the pharmacodynamics of eculizumab, and what it's telling you is that within an hour of administration of the first dose of eculizumab, the ability of the patient's serum to form the membrane attack complex basically disappears and becomes undetectable. So this is a very fast-acting drug in terms of ability to block the complement cascade. And then with regular dosing, weekly intervals, and then 2 weekly intervals, the complement terminal pathway can be completely ablated using this monoclonal antibody. How effective is eculizumab? Well, the answer is it clearly has a beneficial effect in this disease. And what I'm showing you here are the outcomes of open-label treatments. There's been no randomized placebo-controlled trials, but in open-label treatment with patients either progressing despite plasma exchange or patients maintained on plasma exchange, there's a statistically significant and sustained rise in glomerular filtration rate. And this is whether the patient is receiving plasma exchange as an acute setting or for maintenance. In the small number of patients enrolled in this trial, 17, 5 of them were on dialysis at institution of eculizumab, and 4 of those patients came off dialysis. So that's really a great outcome in an otherwise devastating kidney disease. And in about a quarter of the patients enrolled in both of these trials, no mutation was ever identified in their complement cascade. So identification of a complement defect is not a prerequisite for treating with eculizumab. It's the clinical diagnosis of atypical HUS which is the indication. And this is another graph which shows the relative increase in EGFR from baseline in patients starting eculizumab therapy. So what are the adverse effects? Well, eculizumab ablates the complement cascade, and clearly that would increase susceptibility to certain types of infection, particularly meningococcal infection. So patients receiving eculizumab have to be vaccinated so that they have antibodies against the commonly encountered strains of meningococcus, and also treated with prophylactic antibiotics. Neutralizing antibodies to eculizumab have not been described, and so far there haven't been consistently reported adverse events in patients with atypical HUS treated with eculizumab. So what's the role of eculizumab in clinical practice now? Well, clearly it's an appropriate first-line treatment for patients presenting with acute atypical HUS if the diagnosis can be made. You don't need a molecular diagnosis to justify therapy, but you really do need to exclude other causes of thrombotic microangiopathy, most importantly TTP. And where the diagnosis can be made without ambiguity, which is rare, then eculizumab can be used immediately. More commonly, patients are treated with plasma exchange until the relevant blood results are back and then changed to eculizumab. But later on we'll see why this approach isn't necessarily the most always effective. Eculizumab does now allow patients who have lost a graft due to recurrent disease to receive a kidney transplant, and the jury is out as to whether, in the era of eculizumab, combined liver-kidney transplants, which are clearly curative, are indicated. So what are the barriers to the use of eculizumab in clinical practice? Well, really it's cost. So this is a eye-wateringly expensive medication, coming in at £300,000 per patient per year. Now clearly you don't need to necessarily give a year's worth of treatment, and the first dose can be given at a cost of £10,000. But clearly you don't want to be giving this drug to patients in whom it's not going to benefit. So the drug was licensed in 2011, was not available, but there was a high-profile campaign which featured in the high-impact publications such as The Sun, The Daily Mail and Mail Online, and they used very emotive words such as miracle drug and wonder drug, and really the dark figure of Alexion was behind this campaign. But the fact is that following this, the drug has been funded, and in 2013 NHS England has agreed to fund eculizumab for patients in order to prevent life or kidney-threatening TMA. And in their guidance statement they've written, it is a principle to not let anybody with atypical HUS go into irreversible renal failure or die. And really that's what one needs to consider when faced with a patient with either confirmed or likely atypical HUS. Eculizumab is not indicated for drug or toxin-associated HUS or other TMAs such as TTP because it won't work. This drug blocks the complement system, so it will work when the complement system is damaging the endothelium. It will not work, we believe, in other contexts. So this really summarises what we've been discussing, which is that when a patient presents with TMA, the important thing is to, well, identify any predisposing factors, whether that's a viral infection or drugs or other predisposing factors, and treat those. And if those don't exist, to diagnose TTP with an Adams TS13 assay, and if that's negative, the diagnosis is HUS. And really distinguishing between toxin-mediated and atypical HUS depends on identifying a relevant E. coli or other infectious cause. The management then depends on what the cause that's been identified is, and this might be B-cell depletion or eculizumab, depending on the cause. So the take-home message is, don't give platelets, diagnose TTP by Adams TS13 activity of less than 5%. There's no rapid diagnostic test for atypical HUS, but in 75% of patients we can subsequently identify a complement mutation, and it's really important to treat these conditions promptly. Eculizumab is an expensive but effective therapy, and funding is available.